Welcome, everyone. We are going to have a very interesting discussion covering themes of physical activity in geriatric healthcare, psychopathology and physical inactivity, and also exercise as a vital sign. And we have a great guest for this episode. Our guest is working as a postdoc and group leader in Deutsche Sporthochschule in Köln in Germany. His research focuses on sport and movement gerontology in geriatric healthcare and physical activity in aging. Ladies and gentlemen, please welcome our guest, Dr. Tim Fleiner. Welcome, Tim.
Thanks for having me, Ollie.
Yeah, really nice to have you. So maybe we start in the beginning with a little bit of story of yourself. How did you get into this field of research and specialize into physical activity and aging and patient groups?
Well, I've studied physiotherapy, thought about being a pro physiotherapist and going for exercise science. I decided not to go for elite sports, but to go for elite exercise science with a focus on sport and movement gerontology. I've done my PhD in dementia care. I never thought before I would go for geriatric psychiatry, and there was a good chance for me for investigating physical activity and doing an exercise program which showed reductions in neuropsychiatric symptoms. So this was my story to the PhD. And now I'm leading a research group on geriatric psychiatry in motion. I could say I'm a clinical researcher with bedside teaching and bedside research in geriatric healthcare. So that's part of my job.
So a lot of your work is with patient groups, but you are working in university. How are the practicalities of your work? Do you spend much time in the hospital?
Yeah, most part of my work is in the hospital. I've got a shared position half time at the hospital. It's a hospital of psychiatry with a special department on geriatric psychiatry, and also working on the German Sports University with the other part of the time. But all our projects and all our teaching is in the hospital, is with the patients, together with all the disciplines there, that we enable our students to work in such a multi-professional field. And that's my daily routine.
And maybe I think it's interesting, like I have studied sports sciences and I have read about exercise prescription for special groups and so on, but I've never worked with the patient. I haven't spent time in hospitals. So what do you see as kind of things that you don't expect, for example, with the psychiatric patients, like for people who haven't spent time in the hospitals?
We see that there's a cultural change in psychiatry. We see that there's a great need for non-pharmacological interventions, especially as we see side effects of psychotropic medication, especially in older adults, like falls or like more severe diseases. But within this field of non-pharmacological interventions, we see the need and the call for more physical activity. And we see this call especially from the younger nurses and medicals there. And this is something we seek to go for. It's a new field for us. There's nothing happened before in especially geriatric psychiatry. You see young people interested in especially day-night shifts, in having something for the cross-sectoral or trans-sectoral care. This is something where we have good things to do and lots of fun in the hospital. It's a important topic, and that's what we see. That it's not always happy to work there. It's very tight topic and field of care. But with the approach of exercise science, approach of increasing physical activity, detecting physical inactivity. This is something to go structured in this way.
Mm. So a lot of talk also there, or coming, like physical inactivity. Could you tell more about the work you have done there, and how is the inactivity linked to these psychopathologies?
Well, if we look into healthcare, especially geriatric healthcare, we see general low levels of physical activity. Hospital invites people to lie and to sit and not to move. It's also depending on the wear of the clothes. We see there's the public hashtag pajama plagia, or pajama paralysis, that the choice of clothes is related to the level of physical inactivity, especially in older adults. And we see this awareness of physical inactivity. It's coming more and more. So we've got a problem with what is a normal level of physical activity in older adults. Is a patient who does not move, he doesn't catch our attention because he doesn't cause that much caregiver burden. And that's a problem, especially in nursing homes, especially in such an institution where I'm working. And that's the culture of inactivity, culture of take a rest, take your time. And we know all from longer hospital stays that this physical inactivity relates to the muscle mass and to the loss of functionality. So this is the culture of physical inactivity. And what we have done is using hybrid motion sensors attached to the lower back of the patients and asking,
Right.
and asking for asking the patients to rate we ask the nursing staff and the medical staff to rate their psychopathology and the physical activity, and then see where are the correlations together. Because we see that most of the patients do only a few hundred steps a day, and only some patients are wandering patients. They move for about 40,000 steps per day in closed wards. If you see the step length, this is about a half marathon, working on the floor upside down the whole day. So this is someone who causes our caregiver burden, who catches our attention, but we're losing the others. We're losing the one who's sitting all the time, we're lying all the time, because they're not. we don't see these patients. And this is where we have analyzed the neuropsychiatric symptoms. You can do this with psychopathometrics, rating the symptoms, and this is related to the physical inactivity of the patients, especially in patients suffering apathy. Apathy, it's a symptom also in delirium and dementia, and we saw that these people are 30 minutes less active during the day. This was in people with dementia, and now we're working in patients suffering from delirium. Delirium is an acute confusional state, mostly after a surgery or longer anesthesia, and we see motor subtypes. We see hypermotor patients, hypomotor patients, a mixed type and an indifferent type, and especially the majority is the hypomotor, people who don't move that much, and we see higher mortality rates in patients suffering from this type of delirium. That's what now our job is, to assess these patients, to quantify their physical activity levels, and then to derive individualized exercise programs. So not only measure, but also to do something with these measurements in order to improve the situation of the patients in this acute stage of care.
So you mentioned good pajama paralysis, and then the hospital environment, it's built in a way that encourages resting, encourages laying down, and probably the long culture of being patient and just waiting the disease to go away. And now you're looking for intervention to change this. How do you see how can you change it? Is it more individual approaches? Is it environmental changes, or is it more like a cultural change within the nurses and caring staff?
I think it all comes together. You need all of these also behavioral changes aspects. We see that the interest of the patient in their physical activity levels. Some patients, well, we speak of 65 plus, and some of them bringing their smartphone with them, bringing also their smartwatch with them, and don't know about their physical activity levels. This is changing, and we're happy to see what will be about in 10 years. But we see also the multi-professional approach changes, and seeing also the nurses, they see themselves as being responsible. We all are responsible. All therapists, all staff is responsible to be aware of the physical activity and the physical inactivity, especially, and then do something. So we're having the moving corridor. We see that the stairs in the hospital, they are not used for therapy. When we see people are discharged to home, and most of them, they need to be able to climb their stairs, but we're not using them in a way we could use, because this is a resistance exercise going upstairs. This is something we try to bring in to our hospital routines all together. With, as part of our study group, we're bringing ideas, we're developing ideas together, and then bring them into routine care. And the last part is the cultural aspect. This is something where the head is the decisive person, the head of the hospital, the directors, and they see that this cultural change in focusing on physical activity is also good for marketing. It's also good for having the picture outside the hospital, bringing, we're using benzodiazepines, we're using psychotropic medication, but we're also looking at the physical activity status. So this is something where we see in psychiatry, and especially in geriatric psychiatry, an awareness, where we also see that some medicals see themselves, some geriatric medicals see themselves also as sports medicine specialists, because we know the necessity of being active in older adults.
So need to change quite many things and find effective interventions. And you said that some patients are tracking with their smart devices. How do you see the role of tracking in as an intervention that would be provided by a hospital? Have you tried anything like this?
Yeah, we have tried now the step project with pedometers, and having the tracking as part of the hospital routines within ward rounds, within talks to the doctors. And this is something we come now to the point that we also use step counts into the documentation, into the hospital documentation, for also the insurances and also the caregivers. This is something what we are at the next steps, where we also hope that sensors will be able, we need all the quality criteria, but afterwards where also sensors are able to be implemented into hospital routines, documentations. That's a cool aspect for the future. And then we see this tracking as a start of the intervention. We're not tracking steps, physical activity, or sleep for our data, for our qualification, for our publication. We're quantifying this in order to get to know what is around the patient, and then doing something with these data, deriving personalized interventions, then going back to the evaluation. And next step will then be the discharge, in order to make in this acute care an effort and a first step, and then getting them more into having an active way of living.
Mm. And what kind of possibilities you see in the tracking that, for example, you have medication, it might make you tired. So do you think you could use the tracking and the results in the long term with giving indications of some important things in the hospital?
For sure, that's an important part. Also, what the medical staff asks us: do you see differences in the physical activity after changing medication? We have done this analysis with the psychopathology together, and we see no links to benzodiazepines or antipsychotic dosing. This is important because you would think, well, they receive medication that makes them tired, that makes them sitting all the day, and we haven't seen this in 80 patients right now. What we see is the correlation to the day rest night activity, the circadian rhythm. This is an important picture in mental health care, and especially in geriatric mental health care. And the other part, when we see not only quantifying physical activity but also quantifying the balance level of the patients, because we know that the side effects of the the psychotropic medication leads to falls, leads to lower capacities in their balance, the balance of the patients. And this is something we're asked for by the medicals, and there we're experts, and we need values. We don't need assumptions, but we need some data in our hand to speak about, and then to see the next evaluation steps.
Mm. So balance and fall prevention is one big part there. Do you see risks of encouraging movement? Do you get more of falls when persons are actually moving more in the hospital?
Yeah, that's two sides of the medal. And we also had this cultural change in the last 10 years. Perhaps psychiatry also uses constraints. Patients are fixed to their bed in acute situations, let's call it like that. But in the last years, 10 years before, also patients were fixed to their bed because of a high risk for falling. And this is something now that has stopped. Now this is no more allowed. We see increasing numbers of falls, but we also see increasing numbers of physical activity. But this is also these two sides of the medal that we want to have more physical activity and less falls in the patient. So these two parameters you have to be aware of when doing this. But we also, what is the quality of life in there? Patients who are more active, having more with their radius around. We see that this is more important for these patients, and we see in the geriatric psychiatry sample. We see 70.7 falls per 1,000 hospital days, meaning for our hospital, every day 1.5 falls in mean, but we don't see that severe consequences as we would expect there. We see some severe consequences, it's important to note, but not that many as one should think about.
And of course, physical activity has impact on the bone health and bone strength. So yeah,
important issue. But this is also part of the disease, being able to interact with your surrounding, with your world, and not being fixed to a bed due to risk for falling.
And how do you see from the general health point, like probably these patients are mainly doing light intensity activity. Do you think there should be a possibility to do a little bit more moderate or vigorous intensity activity, maybe with the cycle ergometer or some safe way?
Yeah, well, we see the recommendations dealing for 150 minutes in moderate intensity. We're trying to have this into our wards, like in the secured wards, um, being able to move around and do something. This is an important aspect. So having the stimulation of physical activity on the wards, that's a low threshold um, step towards physical activity. So we have ergometers in there, various types of ergometers, standing ergometers, rowing, sitting ergometers. We've got the moving corridor in there where the nursing staff is doing 2 times group exercise per week, per day. Sorry, where also patients are get the role of instructor there. So this is a way to have this low threshold low threshold of getting into exercises. Yes, and well, we also see the level of colleagues, or like say the key of colleagues. How many colleagues do we have there? And we see also an increasing interest in having more physical activity, exercise therapists into the geriatric healthcare settings.
Mm. Yeah, and if I go a little bit jump backwards to these correlation studies, you said that you go psychopathology ratings and then physical activity and look at the correlation, and you said that there is a reduction in the symptoms. Do we know anything about the mechanisms? How does it work?
No, we're at the first steps towards this. There is a group from the Netherlands, from Erik Skerder and Laura Eggermont, who have it's a conceptual paper having the more physical activity, the more agitation in dementia, and they are they are supposing, especially on the stress levels of the patients, that we see stress reactions in dependency of the physical activity levels. This is something which is proposed to, where our first relevant studies right now, but we don't have a clue way in which we will get there. But this is the way it will go, because we also see that this physical activity level is also related to the caregiver level, and if we increase the physical activity, the caregiver burden is decreased, and that's the bigger picture for the dementia care or psychiatric care in its all.
Mm. And did you see similar changes with all different pathologies? You mentioned dementia, delirium, and something else. Do you see similar changes in all different states?
Well, let's first speak about dementia. That's where I've done my PhD, but we're also getting further into this, and we see clinically and statistically significant reductions of the neuropsychiatric symptom as it's in its whole. We have done an exercise carousel, doing exercise 4 times a day, also keeping the day structure in mind, because that's a major problem in the hospital's routines, and there's a quite a good story that the nurses they told us, when you come and the patients get moving, we have a level of burden in the afternoon, and especially need less on-demand medication in the evening hours. That's a good way of summing this up. We see also the level of psychopathology reduced during the study time, but having also this made us smile, because we see these problems with psychotropic medication. This is the part of the neuropsychiatric symptoms. We're actually working on depression. We see geriatric depression as a main problem in older adults, because mostly due to the loneliness. And we have patients in an acute, it's called exacerbation, like acute worse period. And we're now trying to trying to bring them to structured aerobic exercise with ergometers onwards. That's something we're working on right now. We're bringing also the delirium patients together, but that's a new field of research where we need motion sensors to quantify the physical activity levels and behavior, like rest activity cycles, and then go towards personalized exercise recommendations. This is something we are up to new right now, but that's a good perspective.